Med-Surg students, in this presentation, I'm going to talk about neurocognitive disorders. We're going to focus mostly on dementia and delirium and what the difference between the two are. Again, the types of neurocognitive disorders we're going to focus on is delirium and dementia. So delirium is a short-term and reversible state, whereas dementia is long-term and it's a progressive disorder. So the causes of dementia, you can use the mnemonic dementia to figure out what the risk factors are. So the first one is D for drugs, and anticholinergics and diphenhydramine have been linked to dementia. The next one is emotional, and people with depression can sometimes present like people with symptoms of dementia. M stands for metabolic, so this is conditions such as chronic heart failure, chronic obstructive pulmonary disease, chronic kidney disease. So they can present with symptoms of dementia, or they can cause dementia after somebody has had these conditions for a long time. E is endocrine for hypothyroidism or hyponatremia. We learned this semester that sodium really regulates neurological function. So that's interesting. Next semester, you'll learn about thyroidism. Okay. And N is for nutrition. So remember, vegetarians can sometimes lack vitamin B12. So you have to know how to approach nutritional teaching with vegetarians or ovo-lacto vegetarians or lacto vegetarians, okay? Because long-standing vitamin B12 anemia could result in dementia. And then, of course, trauma, or a tumor. So next semester, you'll be learning about brain tumors and also traumatic brain injuries, which can injure the brain and cause dementia. Infections, we don't really see this that much anymore since there's more information out about sexual transmitted infections, but long-term syphilis could cause dementia, and HIV can cause dementia as well. And then A is for anemia, like folate anemia, again, vegetarians. And then alcohol, long-term use or long-term alcohol use disorder can result in dementia. There are different types of dementia. You can use the mnemonic FLAV. And we're not going to go too deep into that. I'm just going to give you little touch points on each one. The first one is frontotemporal dementia, and it really takes over the whole brain. The frontal lobe controls behavior and speech and motor functions. So these are people that have no filter. They could be really nice people, and then remember, this is progressive, right? And then all of a sudden they're just saying things that just do not sound like them. They can be belligerent. They have inhibition, irritable, apathy. So somebody has a change in their personality or outlook of life, and that can be hereditary. Then Lewy bodies in the brain, they can have Parkinsonian-like symptoms and memory loss. People with Alzheimer's, that's probably what you're most familiar with. That usually occurs due to increased age, and they have amyloid plaques in the brain. And then people with vascular problems, like people with long-standing hypertension, people with high cholesterol, people that have had a stroke in the past. So this is just kind of the different types you can have. A less common type of dementia is Huntington's dementia, and this is a genetic condition, so it's passed down through the family, and once somebody's diagnosed, they usually have a lifespan of about 15 years, and it's progressive like most dementias. So it involves impulsive behaviors. Early on, people can think they're drinking, when they have contact with a person. They have jerky, involuntary movements. They have no control over their movements. Irritability, dysarthria, which means difficulty speaking, and bradykinesia, which means slow movement. When it comes to diagnostic testing, there's no one specific laboratory or diagnostic test to diagnose a neurocognitive disorder. There are some tests that can show key features, of a type of dementia. For example, a PET scan can be used to detect amyloid plaques, which is found in Alzheimer's disease. An MRI can be used for frontal temporal lobe dementia, and it may also be used for people who have long-term alcohol abuse because it'll show cortical thinning of the brain. So alcohol abuse can cause cortical thinning of the brain. A CAT scan can be used for people with frontal temporal lobe dementia. It'll show shrinkage of the brain. And then biopsy after death is used to determine prion disease dementia. You've probably heard of mad cow disease. That's what prion disease dementia refers to. Like somebody eats, diseased beef, and then they can years later get mad cow disease. I'm most familiar with Creutzfeldt-Jacobs disease. I've taken care of some people that have had that, and that resulted from eating animal brains years ago, and then they developed this dementia. Genetic testing can be done to detect Huntington's disease. The mini mental state examination is a tool, it's a screening tool for cognitive decline. So it takes about 5 to 10 minutes to administer, so it's practical. It has 11 questions, and there are 5 areas of cognitive decline. They are orientation, which is like what year is it, what date is it, what month, etc. It can also be like, what state are we in, what country, what hospital are we in, etc. So then the next category of cognitive decline is registration. So you name 3 objects and you give 1 second to say, you say each one in 1 second, right? Then you ask the patient after you said all 3 to repeat what you said, and then you give them a point for each one, okay? And then attention and calculation is another category, and this is serial 7. So you ask the patient to count in serial 7s, like 7, 14, etc., okay? And then you stop after 5 answers. Recall, ask for the 3 objects you repeated above. Then language is the other category. And with language, you ask them to name a pencil and a watch, and repeat the following. No ifs, ands, and buts, okay? So it's kind of like they do some language tests, and they have to write a sentence, and then they have to copy a design that is shown to them. So the maximum score is 30, and if there's a score of 23 or lower, it may mean cognitive decline. So patients with dementia use defense mechanisms as their cognitive functioning declines, and this is to preserve their self-esteem. And of course, most people use defense mechanisms to preserve their self-esteem. The first one is denial, and I think you probably already know what denial means. It's when, the client and the family, they deny that there are memory changes taking place, right? Confabulation is another one, and this is when people make up stories or fill in the gaps about stories and events in their life. And perseveration is the client will start to avoid answering questions and may repeat the same phrases or behaviors over and over. So all these are a way to maintain their sense of self-esteem. A few things about normal aging versus dementia. It's normal in the aging brain to occasionally forget appointments, names, and have occasional errors with numbers. They may need help with using new devices, especially when it comes to technology. My father really struggles with that. And then temporary confusion about the day of the week. Remember, usually older adults are not working anymore, so they may not be able to distinguish their days of the week And when you're a nurse, this can also happen if you work nights for a long time because you never know what day it is. And then just kind of compare and contrast dementia warning signs with healthy aging. Okay, so with dementia, it's going to be a noticeably disruptive memory loss. Okay, they can't concentrate on instructions, they can't follow directions, they have difficulty with normal daily ADLs. People with Alzheimer's disease make up about 60% of the people with dementia. And you can remember the 5 A's to remember the signs and symptoms of Alzheimer's disease. And it begins with anomia, which means the inability to remember the name of things, right? They'll call it like the whatchamacallit or that thingy over there, right? Apraxia, they misuse objects because of failure to identify them. Agnosia, inability to recognize familiar objects, tastes, sounds, and other sensations. And amnesia means memory loss. They have memory loss, short-term memory loss. Aphasia is the inability to express oneself through speech. The stages of Alzheimer's disease can be, described as mild, moderate, and severe because it's a progressive disease. So at first, when somebody has mild Alzheimer's, the family might not even recognize that the patient is suffering from Alzheimer's disease, so it's not obvious. They may misplace items like their keys, their phone. This is like the story of my life. Um, they may forget names. And they may start calling people by pronouns like she, her. Neologisms, they start making up their own words for items, and they have trouble planning, like maybe trouble planning a trip, trouble planning meal planning. So just in general, trouble planning. They'll have a mini mental exam of 22 to 26. And then for moderate, this is where they start getting confused to place and time. They need help with ADLs like dressing, possibly eating. You may have to give them finger foods to eat, and check their pockets because they could put food in their pockets and you don't want them to eat it later when it's spoiled, right? Confabulation, so they'll make up stories to fill in the gaps because they can't remember. Wandering, so that is a safety issue you'll have to mitigate. Sundowning, this is when people get more confused at night, and they start having aphasia, receptive and expressive aphasia. And their mini mental exam will be 18 to 20. And then with severe, they have atypical behavior for themselves, like it's almost a personality change. They'll be hostile, irritable. They'll have agraphia, which means an inability to write. Agnosia, which is an inability to recognize items. And then increased reaction. That is referred to as hypermetamorphosis. And what it means is like they want to react to everything in sight. Like, I don't know if you've experienced this, but they'll start touching everything in their environment and explore. Okay. They also have something called hyperorality. And that is like being like a child where they put like everything in their mouth. Okay, so you have to be careful. That's a safety issue. And their mini mental exam is going to be 0 to 10. When recognizing cues in clients with dementia, some of the first cues are related to memory and learning. So some mild manifestations include short-term memory loss. They simply cannot remember recent events. They may need to make a list to do chores, to go shopping. They can't remember everything in their head anymore. And remember, this is a progressive disorder, so at some point they may become unable to keep track of a list. They may have the list with them, but still forget to pick up the items on the shopping list. And they may become repeaters. They may start repeating information, so you may hear the same stories over and over again. Clients with dementia also have problems with language, At first, when the symptoms are mild, or if they have mild form, they may have difficulty finding words. They may substitute words like, say, that thingamajig or that thingy. You know what I'm talking about, right? They may think things like that, so they may substitute words. They may develop neologisms. That means they develop new words for something when they can't remember the name of something. They are going to have expressive aphasia, meaning they may not be able to talk, or they may also have receptive aphasia, meaning they can't understand what you're saying. So remember, aphasia means the inability to express oneself through speech. So they have problems with language. When it comes to social issues, people with dementia often become or have restlessness and they wander. Um, they can become hostile. They are no longer empathetic. You may see that in clients. They may have personality changes, like changes in their behavior and attitude. They may be insensitive to manners and be rude in conversations. And they also may make some poor choices, so this could be a safety issue. People with dementia may start having difficulties with motor and perceptual issues. For example, you may notice that they are less precise when they're parking their car, so they have difficulty parking their car. They need a map or directions to get anywhere, and they must concentrate when they're driving or walking, or they'll get lost. And they are also prone to sundowning, meaning they get confused at dusk. People with dementia have trouble with complex attention, so that refers to like their attention span, their ability to process what you're saying to them. So they may early on take a little bit longer to do their tasks because they have to double check each step of the way. Okay, they early on will need like quiet environments so that they can think. So like no music on or no TV that's distracting them. They're easily distracted in stimulating environments, and they have a hard time processing information in those type of environments. So they need simple directions and very little choices. Like I wouldn't give them a choice, like it is time to eat breakfast, right? Not would you like to eat breakfast or have orange juice, thinking process is slower. It takes them a little bit longer to think and process, so you're going to have to give them time if you're having a conversation with them. Recognizing cues of patients in dementia, when it comes to their executive function, which involves planning, decision making, responding to feedback, and their mental flexibility, they have difficulty multitasking. So they may need to put more effort into a multi-stage project, and then as the disease progresses, they may stop doing complex projects altogether and focus on one task at a time. All right. They may need others to plan activities and make decisions for them. They may decide to stop traveling because airports are too confusing to them. So these are some of the things you might see in people with dementia. Nursing care for clients with dementia, you need to keep them safe. That is a primary goal, okay? So you need to prevent falls, and I know you've had fall precautions before. You need to engage in wandering management techniques. You need to put, when they first, especially if they first come in to either the hospital or a skilled nursing facility, they should have a room near the nurse's station. They need a well-lit, quiet room. You don't want them to get anxious because of the noise, okay? And then room with a view. Room with a view, room with a window is always a great thing for people that are at risk for dementia or delirium because it helps reorient them to know when it's nighttime and to know when it's daytime. use beds and wheelchair alarms, have the client wear an ID bracelet in case they get lost, and then a bed on the floor enhances safety as well. When it comes to home care, you're going to want to assess the level of supervision. Is it appropriate for the stage of their illness? There's a lot of safety issues with somebody with dementia being at home alone. So you want to encourage the family to practice hot water and oven safety. That means setting the hot water to 120 degrees Fahrenheit. Um, the, the patient should be wearing a tracking device, especially if they're at the stage where they're wandering. You need to prevent elopement, teach them how to do that with locks and alarms on windows and doors so you can hear if they're leaving. No driving. At some point, people with dementia have to give up driving. Use bed monitors also for wandering and preventing elopement. Alarms and windows need to be secure, and um, there should be safety rails in hallways, on the steps, in the bathrooms. And then you want to remove any dangerous, sharp objects at some point, depending on the progression of their disease. To provide cognitive support, you want to have clocks where the clients can see them, and also calendars so that they can kind of get an idea what time of day it is and what month it is. To provide cognitive support, you want to have their rooms with a calendar they can see and clocks, and if it's in a facility, the same thing. There should be calendars, clocks, and schedules. Okay, the patient should have a consistent schedule so they're doing the same thing every day, and that'll reduce anxiety. They should also have consistent caregivers. I worked in a nursing home when I was 16, and I worked in a nursing home for 7 years. And even though a lot of the clients had dementia, they still knew I was somebody that would help them. You want to cover or remove mirrors. You want to, so they don't get anxiety. And then encourage exercise during the day so that they can sleep at night and you won't have to worry about wandering. You want good lighting in the room at night, and you want an uncluttered path to the bathroom. It drives me crazy when I walk into somebody's room and there are shoes that are not in a place that is not in the path to the bathroom. Diet and exercise can slow the progression of dementia. The MIND diet is a type of diet which combines the DASH diet, which is the dietary approaches to stopping hypertension, and the Mediterranean diet. So it involves low salt, omega-3 fatty acids in the diet, lots of fish, flax seeds. These type of foods can help slow the progression of dementia. To decrease risk of getting one of the flaw, eat food high in flavonols. So oranges, spinach, tomatoes, and pears may help decrease the risk of obtaining Alzheimer's disease. To support cognitive function, omega-3 fatty acids can be included into the client's diet. So fish, nuts, and green leafy vegetables are very good choices. Music therapy is an effective strategy. It evokes happy memories in people with dementia. It also improves the appetite. If in some skilled facilities I worked at, they would get up and dance, they would have dances, and it decreases depression. Delirium is another neurocognitive disorder that you may experience in hospitalized older adults. Now, the difference between delirium and dementia is that with delirium, there's a short onset and it occurs over hours to days, whereas we talked about dementia being more progressive in declining over a number of years. Okay, so some of the causes could be an older adult that has like an infection, like a UTI, or maybe they had surgery and now they're having an infection. They may be malnourished, depressed, electrolyte imbalances. Remember, low sodium could cause some neurological problems, and then history of substance abuse. So especially like people that have surgery or people that drink a lot, you want to know when their last drink was, because they can start experiencing delirium if they're going through delirium tremors. So the causes of delirium can be remembered with the mnemonic delirium. So drugs can cause delirium. So like street drugs, but also drugs that are medications, I should say, that people take for, psychiatric diseases or, neurocognitive diseases. They could become toxic with it. Electrolyte imbalances. I talked about sodium before. People with liver failure. The liver detoxifies byproducts in our body. So there could be an increase in ammonia level in the body, and that can make people a little crazy. And hypoxia, of course, can also do that. People with liver failure also have a reversal of sleep-wake cycles, so that they could become sleep deprived. Infection is another cause of delirium. Retention, both urinary and constipation, can cause delirium. Intracranial problems, I talked earlier about brain tumors. Uremia, uremic products are a byproduct of kidney disease, and uremia can cause encephalopathy. And then metabolic problems, I talked about thyroid disease, etc. earlier. Delirium is a medical emergency. It needs early intervention, and it's temporary if you have early intervention. So patients may present with hyperactivity or restlessness. They may be trembling. Their sympathetic nervous system can be triggered, so they'll have tachycardia, diaphoresis, maybe an increased blood pressure. They'll suffer from nausea and vomiting. They have a rapid personality change. They could have seizures due to, if they have a low sodium. They could have hallucinations, and usually the symptoms are worse during the early AM and in evenings. They can also have like apathy and signs of hypoactivity. Delirium presents with an altered LOC. They could be extremely anxious, restlessness. They could be apathetic. They have rapid mood swings. Their family doesn't recognize the mood swings. They can be paranoid, anxious. Their speech can become incoherent and inappropriate. They could be rambling or have rapid speech. Delirium is treated by identifying the cause and treating the cause. Medications can also be used, and I know you're learning about that in pharmacology. You want to keep the patient safe, just like you would with somebody with dementia. Update your whiteboard if they're in the hospital daily, and when you need to. Encourage PO fluids, ambulation. Now, this could be a safety issue, so they need to be ambulated with assist. Vision and hearing aids, so make sure they have their glasses, their hearing aids, and manage pain and promote sleep.